Hello, I'm absolutely delighted to be taking part in the IPC Take 10 series, and this is going to be a double act between myself, Chris Griffiths, and my colleague, Dr. Lwin. And we're going to tell you about the use of mesenchymal stromal cells, MSCs, for severe biologic-refractory psoriasis. For those of you who have been involved with psoriasis research and management, and I guess all of you will have been because you're IPC counselors, will know that over the last 25 years, we've made very significant progress in understanding the immunology of psoriasis. As a consequence of being able to translate that into targeted immunotherapies called biologics. And if you look back over the sweep of the last century, from the 1920s to the current day, you can see over the last 20 years, the speed of change has really accelerated, and that's because of that translational approach that I've just mentioned. And we're now in what's known as the biologic era of the management of psoriasis, and particularly moderate to severe psoriasis. And we now have 4 classes of biologic therapies, which I think it's fair to say have been transformational for the lives of people with severe psoriasis across the world. The 4 classes target interleukin-12, 23, such as ustekinumab, interleukin-23, P19, and interleukin-17. There's a number of different approaches to interleukin-17. And then the now becoming more old-fashioned TNF-targeted therapies. And with the introduction of biosimilars for ustekinumab and also TNF targeted therapies, we should be able to, with the help of the WHO, increase the access to care for people with severe psoriasis. So despite this tremendous progress with the biologic therapies, some people may say, well, we've now solved psoriasis. We don't need to be looking for new treatments. But the problem is, and most of you all have seen patients such as this, some patients don't respond. Some patients go into what's called secondary failure, where they fail a biologic after a period of time, then have to switch over to a second biologic. And in some cases, and it's not as rare as one might imagine, patients have been through all 4 major classes of biologics and have gone through secondary failure after secondary failure. And these are patients who we have what's called recidivist psoriasis, and that it can't be controlled or kept in check for any long period of time. And most dermatology centers in Europe and I guess around the world will have a number of these patients, and these patient numbers are only increasing. So the question is, what can we do to help these people? Well, we could be able to use the current biologics much earlier in the disease course, or we could turn to what are known as advanced therapeutics. Now, why would I say advanced therapeutics? Well, biologics were advanced at one time, but no longer are advanced. They are now the normal care. There's some clues as to how we should proceed from what we've observed clinically over the past 30 years. There are some patients who've got psoriasis and unfortunately have developed a B-cell leukemia or a lymphoma and have received a bone marrow transplant, either autologous or allogeneic, for treatment of the malignancy. Malignancy has gone into remission, and in some cases, particularly with allogeneic transplants, the psoriasis has gone into long-term remission and maybe perhaps even a cure. An intriguing observation, which implies that maybe a component of bone marrow, maybe cell-based approach, might actually give the opportunity to have much better control of severe psoriasis, which leads on to what's called cell-based therapy. And biologics or small molecules that we currently use are probably not going to be curative for psoriasis, unless maybe they're used very, very early in the disease. But I believe, and I know Dr. Lwin also believes, that maybe the best chance of cure is using these cell-based therapies. We're going to discuss with you one particular form of cell-based therapy, that's MSCs or mesenchymal stromal cells, which can be derived from a number of different tissues, such as adipose tissue or umbilical cord or bone marrow. I'm now going to hand over to Dr. Lwin, who's going to take you through cell-based therapies and also the study that we recently published on the use of MSCs for severe biologic refractory psoriasis. Over to you, Sue.
Thank you very much, Chris. So it's my absolute pleasure to expand a bit more about these cell-based therapeutics approaches for psoriasis. But of course, I come from rare disease background in EB, epidermolysis bullosa in particular. That's where we have been utilizing stem cell and gene therapies for over a decade. And it's absolutely very exciting times to be able to apply what's been developed in rare disease to a common disease such as psoriasis. So first of all, what are MSCs? So these are somatic stem cells. These are multipotent cells with specific marker expression. And as Professor Griffiths mentioned earlier, they can be easily harvested from multiple sources of tissues, and commonly adipose tissue, and also in particular umbilical cord and bone marrow as well. They are unique in a sense that they have low immunogenicity, therefore no preconditioning regimen is required, and that's because they do not express MHC class 2 and a little bit of MHC class 1. And there are more than 1,000 completed or ongoing clinical trials of MSCs being used in various immune-mediated inflammatory diseases, including inflammatory bowel disease and arthritis. They do have very good safety profile overall. So this is more of an entry-level, safe form of stem cell-based therapeutics that we can utilize in skin diseases such as psoriasis. How do they work? Well, there are two main properties to MSCs and how they work. One is that they are immunomodulatory, and in particular, they can downregulate Th1 pathways and Th17 pathways relevant to psoriasis. They can also upregulate anti-inflammatory cells such as regulatory T cells and M2 macrophages. They have various ways that they affect immunomodulation through paracrine effects, perforin-dependent apoptosis, releasing anti-inflammatory factors, and as well as cell-to-cell contact. They are also known to be regenerative through release of extracellular vesicles containing growth factors such as VEGF and EGFs. They are also pro-angiogenic. So these have been utilized in recessive dystrophic EB more than a decade ago, and already we learnt from those trials that children respond better to MSCs than adults. Again, learning about the importance of early intervention. Now, based on these experiences, there's a strong rationale, scientific and clinical rationale, to utilize MSCs for their immunomodulatory effects as rescue therapy in biologic-refractory psoriasis that Professor Griffiths mentioned earlier. And we treated 3 adult patients with severe multiple biologic-resistant psoriasis using systemic allogeneic umbilical cord-derived MSCs. And all 3 patients have undergone at least 5 different biologics across all 4 classes already, and they are failing on their last biologics. And we used approximately 3 million cells per kilogram dosing of UC-MSCs at day 0 and 7 on compassionate grounds. So this was not set up as a clinical trial or research study, but because they are running out of therapeutic options, we were able to provide on compassionate grounds. In terms of clinical response, out of the 3 patients, 1 out of 3 patients achieved 87% improvement in PASI by week 4. This is significant for this particular patient, considering this is the best response that she has experienced in her life. 2 out of 3 patients had an absolute PASI of less than 2, lasting more than 2 years after restarting a previously failed biologic. So in the patients, the 2 patients, we gave them a full washout period and restarted them once they flared again, restarted them on a previously failed biologic. So this is a very exciting finding, that the previously failed biologic is working again. And all 3 out of 3 patients tolerated the MSCs well and had no safety issues. So this is to demonstrate patient number 2 in particular. You can see on the graph, the straight lines are PASI, dotted lines are DLQIs. She has gone through various biologics previously. We gave the 2 infusions of MSCs after pausing guselkumab. And after the MSC infusions, you can see the PASI dropping down to 87% by week 4. But she did flare again, and that's when we restarted guselkumab, and her PASI has been really very, very low, less than 2 for over 2 years. These are before and after images of patient 2 on the left at baseline in week 4, and patient number 3 at baseline week 9 after the MSC infusions, but she then had severe sunburns being abroad in Spain. And so when she flared again, when her psoriasis flared again, we then restarted her on bimekizumab that we paused, that she was failing previously, and she had almost clear skin by week 17. In terms of immune data, it was really quite fascinating to see that there were overall increases in the frequency of skin homing and skin recirculating T cells in the PBMCs on flow cytometry. There were also increases in frequency of Tregs in all 3 patients, as well as phenotypic shifts in monocyte subsets. So overall, in these 3 patients who are multiple biologic resistant with severe psoriasis, we treated them with allogeneic umbilical cord MSCs, and they were all well tolerated. There was direct clinical benefit, but variable between the 3 patients, so we can learn a lot more about patient stratification and predictors of response and so on. But really fascinatingly, and this is the exciting part, there was sustained enhanced response to previously ineffective biologic in 2 out of 2 patients when we restarted the biologic. And there was evidence from immune profiling that MSCs could potentially reset the immune response. Of course, this was a very small sample size. And again, as I mentioned, these patients were treated on compassionate grounds, and we only performed descriptive analysis, limited dosing of MSCs, and also clinical visits of assessments and sampling were varied between patients due to clinical grounds. And however, this actually provides us with very, very promising data. So the next step for us is to conduct a phase 2 clinical trial of UC MSCs in refractory psoriasis, first of all, to really confirm the findings of the efficacy of MSCs. Do previously failed biologics will respond again after the MSCs in certain patients, and also to confirm the safety profile. But furthermore, we can really dig deeper into the mechanistic insights of how the MSCs work, as well as how they potentially reset the immune response. Thank you very much, and hopefully this was informative, and we are very excited for the era of cell-based therapeutics approaches to treat psoriasis.